Elle Gunderson, a doctoral student of occupational therapy at Touro University, Nevada. I'm super excited to share my program and findings with you, so let's go ahead and get started. Okay, my program is centered around Centennial Hills Hospital in Las Vegas, Nevada. It's a for-profit hospital, and it's part of the 6-hospital Valley Health System within the greater Las Vegas Valley. It has 226 beds, and it's located in the northwest part of Las Vegas, Nevada. It is known for women's health, and it has up to a level 3 NICU. It also has many natural birthing options. During my planning phase for this program, I completed a needs assessment, which included 3 different assessments and then also an interview. So I interviewed my community mentor, who is an occupational therapist within the NICU. And then I had assessments for occupational therapists, mothers, and maternity care nurses. Each of these 3 received a Google form assessment to complete, and then it was all anonymous and it was returned to me. I found each of these people either through specialty Facebook groups, acquaintances, or people that I had professionally worked with. So this proposed project, the concept includes postpartum post-traumatic stress disorder. That's the main focus of it. Sensory processing and postpartum PTSD, memory consolidation, neuroscientific approach to each of these things, and education. That was the basis of the planning for my program. This program has the following goals. So I want to educate mothers, educate maternity care nurses, demonstrate the value of occupational therapists within women's health, also educate occupational therapists, and prevent long-term consolidation of birth-related traumatic memories. Within this program, I based it off of the information processing theory, which we're going to get into, but this really taps into the ideas of sensory processing and occupational therapy, how we are preventative, and how we can use occupation to help mothers prevent the development of PP-PTSD. So let's go ahead and dive into the proposed project theory. And this was the main theory that my program was created on. So the information processing theory starts with, input. And this input can be internal, external, or it can be feedback about responses. And we'll get through all of these. So you think about it, I do wish that there was an arrow from the internal to the external, because we know that our bodies process sensations, not like here's the outside world and here's the inside world. The way we perceive the outside world starts with us on the inside, okay? So you can't really have the external stimulation as an input without the internal processing of that and how it is going along with the internal information that's happening in our bodies. So the internal sensations would be things like, what do I see? What do I smell? What do I feel with my fingers? Where is my arm in space? And things like that. Whereas that external information is going to be coming in more so about, do I smell something? What's in my environment? What in my environment is causing those things within me, like my sensation of scent? Why am I feeling the sensation of scent? And then I realize, oh, there's a smell in the room, right? So it's kind of a little bit of both. And that's why I wish that it showed some kind of relationship between the two in this model. So once we have that sensory information that has gone into ourselves, into our brains and our bodies, we then register this sensory information and we kind of make sense of it all. We process it. And part of this processing is the fact that you may lose information through decay. So maybe you're not, it's just not registering in your system. Your body isn't sensitive to sight, sound, smells, whatever, and it kind of just ignores it, okay? Maybe there's problems with your memory. Maybe you've had a traumatic brain injury, or you have some kind of disability that impacts your ability to store those memories for longer than a few seconds. So there's many reasons why. Maybe you're distracted, maybe you're thinking about other things, and that causes decay in the registration of that sensory information. You're thinking about what to make for dinner, like me. All right, so also with the registration of sensory information is the executive control or the metacognition that goes along with it. So I have stars next to the following: regulation and allocation of attention to processing, regulation of information processing strategies, and then cognitive effort. So we're seeing a whole lot of regulation, okay? It does take a great deal of regulation in order to store memories. So that's a big part of it, as far as that, as also that cognitive effort. If you're not trying to remember something, there's a good chance you won't. All right, and then moving on to that short-term to long-term memory. As you can see in the schematic, this algorithm, there are arrows frequently going back and forth. And that's because that's the way our brain works. Our brain doesn't have like one road. It has, like in Las Vegas, we have the spaghetti bowl, right? That's where we have a few freeways that meet up. So you have this big bowl of spaghetti and they kind of cross and they come together. That's the way the brain is. So there's going to be a lot of back and forth. All right. And so when we're looking at the short term working memory, it does turn to long term memory. And then when we have long term memories, that impacts the way that we experience our short term memories. So it goes back and forth. I have a star next to the decay of information. So that's lost information due to decay of information. And that is actually what I am aiming for when we talk about moms. When we're talking about healthcare workers within my program, I want the exact opposite. I want them to retain the information I'm giving them, and I want to store them long term, and I want them to be able to retrieve them through their actions. But with moms, I think as far as the healthcare workers, that's a lot more straightforward. I think most people understand that we want to facilitate people to remember what they're taught to remember, right? But I think it's a little bit more of a foreign idea that we want people to not remember. So I'm going to focus on that in this presentation. So let's think about moms with this, that when they have a traumatic event, and that can be like a traumatic birth that they perceive. For example, it's not like they had an emergency C-section or any emergency measures, but rather they just felt like they weren't safe, or they felt like their children weren't safe. When that happens, and that's a perceived traumatic event, and that is a greater predictor of the development of post-traumatic stress symptoms than like something like I look at someone and said, oh, obviously they had a traumatic birth because they had a C-section that wasn't planned. Okay. There's a good chance that person with a C-section did have a traumatic experience, but then there's a chance they didn't. And there's also all these other people you're missing who did perceive a traumatic event, although you did not as a healthcare provider. So we need to remember moms need to be asked about this. And when the mother perceives that she had a traumatic birth, then those short-term memories become that fight, flight, or freeze type of memories, right? So when we're in a traumatic situation where we have cortisol pumping and we're scared for our lives, our body takes in more visual spatial cognitive information, and I'll tell you what that is, than is typical of what you see. You notice a lot more things in your environment when you're in the fight, flight, or freeze, right? You notice more spatial things. So like how far away is the table? How far away is the door? How far away is the exit of the building? And all of these things are then thought about cognitively in a very rapid way because you're making life or death decisions. That's the way we're wired. So all of that is fine until it's not. So the things that would cause it to not be fine are, for example, if you store all of those things in your mind and without pruning, without getting rid of any of it. So let's say that I remember all or most of those traumatic visual experiences. I remember all or most of those traumatic spatial experiences and all of those cognitive experiences, trying to make sense of it and figure out how my body's going to respond to to a life-threatening event. And because our body is not used to that much information, storing it is a bit of a mess. And if your body just holds on to it and doesn't get rid of some of it, then you are going to most likely end up with PTSD symptoms, signs and symptoms. So those might be nightmares, right? Visually rich nightmares. When you are having maybe flashbacks to the event, maybe you're walking around and you're seeing and perceiving things that aren't real for your space and time. Okay, maybe it happened a few years ago, but all of a sudden it's like you're reliving it. All of these things come from that memory system, right? That visual spatial cognitive memory that is not being stored properly. In fact, it shouldn't be being stored. Most of it shouldn't be stored anyway. A lot of it should be ex-nate. So that's what we're trying to do. We're trying to hack that system and get mothers to let go of some of those traumatic memories that don't help them. It's not like we're trying to get rid of memories of baby or the joy of becoming a mom or the experience. It's just trying to prune out some of those unnecessary visual, spatial, and cognitive memories. All right. So once we get to the short-term and long-term memory, past that, then we go to output. And it's really what we know that determines how we act. So if I learned healthy things, good things, things that will help me in my life, then I'm going to have thoughts and behaviors that are going to follow that. So I'm going to be able to make better decisions, make healthier decisions, impact my own life in a positive way, as well as impact my infant's life in a positive way. Now, if we have negative memories, negative experiences, then that's going to more likely than not negatively impact my life, the life of my child, and our outcomes. And then that happens not just because of one individual action, but that also there's that feedback loop heading back to the input of sensory information. So some life events can kind of shade the way you perceive things going forward. And that's another problem, right? And it's harder to break once that's set in stone than to prevent it from happening altogether. So the aim here is really to prevent that from happening altogether. All right, so now we're looking at executive control, right? That metacognition. That's our target. The executive control, or the metacognition and information processing theory. We want to hack that to help in the process, to help with the decay of information. That, when I speak to a mother and I say, I assess them for a traumatic birthing experience, and then I say, okay, I have a preventative measure that, if done in X, Y, and Z ways, can help you to prevent the onset of symptoms associated with PP-PTSD. Then they can use their metacognition to hijack the whole system and help prevent a negative outcome. All right, so now looking at the program plan, there are 6 podcasts planned that have not yet been recorded, and these 6 podcasts will be available to anyone who wants to listen to them, but they will be allowed as CEU credits for nursing staff and occupational therapy staff within this hospital system, as long as they complete the 6 associated quizzes. So those are the 6 nurse and occupational therapy quizzes. And then there's going to be a universal traumatic birth screening for every mother that I see within 6 hours of giving birth. Now, there's only one of me, and I'm here for 40 hours a week. So I am not going to be able to see every mother who gives birth, because if there's a mom who gives birth on Friday night or Saturday night, even Sunday night, if it's early in the evening, I won't be able to, help them. I still may assess them, but I'm not going to be able to provide preventative measures, because the preventative measures I'm using are meant to happen within the first 6 hours of giving birth. So with that, I will kind of give them access to my website and give them information and things to look out for. Okay, and then there's going to be the visual spatial cognitive intervention. And this does say by maternity care nurses, but that was due to potential COVID restrictions of me not being able to be in the hospital campus, but that's all been rectified. So that will be done by me. And then I'm going to have follow-up. So I'll have some follow-up assessments, just kind of chat, have them do some screeners. And if it's looking like they may have some signs and symptoms of postpartum depression, postpartum PTSD, postpartum anxiety, all of which are they're being lightly assessed, I will instruct moms to talk to their general practitioners about that. All right, so looking at contextual factors in terms of management and delivery, right now, COVID-19 is the name of the game. The immunization is out, but not everyone has had access to that, and it's still deeply impacting the way the hospitals are run. For example, mothers are only able to have one birthing partner present. Everyone needs to be in masks. If the child needs to go to the NICU, only one parent is allowed to visit the child in a day. And once they leave, that's it. They can't come back that same day. So as you can see, there's a lot of ways that COVID-19 is changing things or has changed things. And so it's something that I've had to plan around and keep in the back of my mind as I approach this. Nursing and therapists and therapy misalign perspectives. So what this means is nursing staff is coming into this with a focus on mother and baby physiological stabilization. They want to make sure that mommy and baby are safe and they're living. But oftentimes the psychological stabilization is just kind of ignored. And that's because nurses are very busy with their focus. And so really we do need a different healthcare provider coming in and assessing mental health and other areas and providing interventions, preventative information and interventions for these moms. And this is a role that occupational therapists are perfect for. Okay. And then also, there's the oversight of nursing staff. This is less of an issue now that I know I can be on campus. Before that was more of a concern if I was going to have to do things remotely. And then finally, communicating podcast resources to pregnant women. I do have some pens that are currently being made with this information, and those moms are each going to receive one to help them remember the website as they go home and they're busy. That way, when something comes up and they're worried or they want to look into something, they can go straight to that website. They'll have that pen and they will not have forgotten it by then. So within the demonstration interviews, okay, I'm just going to go briefly over my assessments for all of these things. But just first off, I wanted this to be versatile. I wanted this program to be made for moms and practitioners. And I wanted many of these items to be available online for any other OTs in women's health, for nursing staff in women's health, for OTs in school still learning, for mothers who are seeking out information. I wanted it to be versatile and available to everybody. I've been careful to structure my plan so it can be expanded and or contracted as needed. Because of COVID, I had layer after layer, plan A, plan B, plan C. I mean, honestly, probably down to plan Z. I had so many plans just in case because the world has been a wild place lately. Okay. And really what I want to do is I want to merge the lived experience with the academic side. So I want things to not just be academic. I want some academic information to be provided, but also for the layman crowd. I think that's important. All right, so we're going to keep going on. So the program timeline. So originally thought I was going to have to do some Zoom training for nursing staff, but since I'm on campus, that one is no longer a concern. And then I'm going to be doing this universal traumatic birth screening for moms. Every mom that I'm able to see, I'm going to go ahead and do that. And then for moms who have had a traumatic birthing experience within 6 hours of me being able to help them, I'm going to do a visuospatial intervention. And what that is that's like Tetris. That's what was researched is Tetris. And they had good outcomes with that, preventing PP-PTSD symptoms from occurring. And they expanded that to perhaps Candy Crush might work. So I'm going to have Candy Crush also for mothers to use. And then based off of that information, the occupational knowledge that I have, and the visuospatial focus. I also have word searches available and picture finds available for moms. Then I'm going to do a baseline assessment for mothers. I'm going to be recording podcasts, advertising those, letting moms know about it, letting healthcare practitioners know about it. I'm going to then do a follow-up assessment um, for moms after a month or two. I have not decided that one yet. 2 months would be optimal, but due to the limited length of time that I have 3 to 4 months for this. I may have to do just 1 month. And then these podcasts are going to be posted, and there will be quizzes available for those CEU credits within Valley Health System. All right, so that is the general idea for this program. Obviously, I've made it past the approval stage. I'm here and I'm ready to work. I just wanted to share my thinking and my reasoning on how I arrived here and what kind of fed into it. So thank you so much for listening. If you have any questions, go ahead and email me. The email information is on the website, hbdprogram.com. Here are the references. If you need any other references outside of this that I've mentioned at other times, just email me and I will find them for you. All right, have a nice day. Thanks again.